So this year's European School of Hematology Acute Leukemia meeting, the talk that I'm going to give, which will be virtual, is focusing on immune checkpoint-based treatments in acute myeloid leukemias and MDS. So this is a field that I've been very passionate and worked on now for the last 6 years or so. We were probably one of the early adopters of the immune checkpoint-based treatments in acute myeloid leukemia, MDS, and also in CLL at MD Anderson. It's kind of been mixed results. We've had some positive findings. We've had some very interesting correlative findings. And I think it's really sparked off a lot of different immune checkpoint studies across the country, across the world, as well as a lot of work looking at the immune biology of acute myeloid leukemia. So, from the biology aspect, when we started 5-6 years ago, there was very limited data out there about the immune microenvironment. Everybody was focusing very heavily, and still, of course, is, I think, primary the molecular microenvironment, as well as other tumor microenvironment factors and pathways. The things we did know is that there was actually very reasonable T-cell infiltration in the AML bone marrows, and actually our group and others looked side by side at bone marrows from patients with newly diagnosed and relapsed AML and healthy individuals. And what we found is whether it's a percentage of total bone marrow infiltration or its absolute number of T cells on medium power fields, there was actually quite a degree of similarity between healthy individuals and AML patients, both newly diagnosed and early relapsed, which was interesting, basically suggesting counterintuitive to what many of us think, there is in fact a preserved T-cell infiltration population in the bone marrow. Now, what we didn't know was what is the functionality of those T cells. And over the last few years, again, our group, as well as other groups, including, for example, Ohio State, have looked at this, as well as Oregon Health University, and have shown that, in fact, there is, especially in newly diagnosed AML, a good degree of functionality. And we looked at this using single-cell broad cytokine profiling, using a technique called isoplexis, and we found that in new AML, in fact, the diversity as well as the total quantity of Th1 cytokines that can be produced in AML bone marrow T cells is very similar to healthy individuals, except for, in fact, TP53. And the TP53 patients, even newly diagnosed and for sure relapsed AML, had significantly abrogated T-cell, single-cell cytokine production ability, both as quantities as well as diversity. So to us, it appears that T-cell TP53 mutations don't only impact the molecular machinery, but also seem to impair the T-cell functionality, at least when we look at it by stimulated T-cell, single-cell cytokine production. But the point is that there are T cells in the bone marrow. They are functional in the majority. What we do see is when you look at advanced salvage 3, 4, and 5, that's when you start seeing big numerical drops in T cell population, as well as big functional drops in the T cells that are remaining. And that's probably partly because of all the prior therapies that patients have received with purine analogs, fludarabine, clofarabine, cladribine, which are very T lympholytic. So I think just like we're seeing in acute lymphoblastic leukemia, just as we're seeing in certain types of lymphomas, probably the best use of these immune therapies, whether it's checkpoint or CAR T cell, is going to be early on, either MRD setting after induction or frontline treatment, or in first salvage scenarios. So we've done some of the clinical trials. One of them is the azacitidine nivolumab. This study looked at 70 patients, all relapsed refractory AML, predominantly older relapsed population. And we published these results last year in the Cancer Discovery. Overall response rate was about 35%, including about 25% CR/CRi. This compared favorably to a matched historical clinical trial group treated on other HMA-based combinations at MD Anderson in a similar time period. Response rates were better, overall survival was better, but really it was the salvage one, which was half the population, about 35 over 70. When you look at the salvage one, the median overall survival on AZA/NIVO in this older relapse salvage one was almost 10 and a half months. That's really quite encouraging and better than what we have seen with most treatments in salvage one situation, including even HMA venetoclax. So again, I think, using these immune treatments in early salvage, when you have preserved T cell function, you can harness the T cells, is probably most important. The other thing we did is a lot of immune correlatives on the study, and we found that patients who at baseline had a higher degree of T cell infiltration, this was a percent infiltration of the bone marrow, tended to have a higher chance of achieving response. So again, showing that there were some patients with AML who already had a response being generated against the AML in the bone marrow T cell infiltration, as opposed to others who had an immune desert type of bone marrow scenario. And you could then select the patients who already had an immune T cell infiltration for immune checkpoints. And there you could get high response rates. When we had people with T cell infiltration greater than 14% in the bone marrow, the response rates were almost 55, 60%, as opposed to those with less than 10% T cell infiltration, where response rates were 20%. So I think this could become a very useful biomarker, just like we use FLT3 IDH for the molecular world. The other things we're looking at is combinations. So we have combinations of AZA nivolumab now with ipilimumab. That one's still maturing. We presented the data as an oral at ASH2 of 2019. Hopefully we'll be updating later this year. We're seeing some very interesting responses there, especially in post-stem cell transplant and patients with extramedullary disease. We had 4 such patients with extramedullary disease post-transplant, and all of them have had a very nice response in extramedullary disease and also in the marrow in that scenario. This is something that the Dana-Farber group had shown a few years ago, that ipilimumab post-transplant was very effective at getting remissions in people with relapsed AML, especially extramedullary disease. Now, other groups are also looking at it. The Hopkins group has looked at combinations of azacitidine with pembrolizumab, which is another PD-1 inhibitor, both in relapse and frontline older, ineligible for intensive chemo AML. Response rates in the relapse population very similar to ours, 30% or so. Both our group and theirs have seen immune toxicities. This is very important to highlight. Immune toxicity rates are 20 to 25%. These are grade 2, 3, and 4. The good thing is, if identified and treated quickly with steroids, almost all of these resolve very rapidly, and rarely do they progress to severe multisystemic or uncontrollable immune inflammation. But we do have to be aware of them. There was a randomized phase 2 study looking now at a PD-L1 inhibitor, so different from nivolumab pembrolizumab. The PD-L1 inhibitor would do durvalumab with azacitidine as compared to azacitidine alone. And that study looked at about 120 ml, 60 who got aza durva and 60 who got aza alone, and did not show any clear response benefit or survival benefit. Now, our lab has been looking at PD-L1 versus PD-1 inhibition. We did have a trial with another PD-L1 inhibitor, avelumab with aza. And one of the interesting things we found is that the response rates per se was actually much lower, only about 10% in relapsed AML with aza durva compared to 35% with aza nivo or aza pembro. But more interestingly is that when patients who had some response or significant blast reduction again relapsed or progressed, there was very high PD-L2 expression on the AML blast. So it may be that if you just do PD-L1 inhibition, the tumors are frequently able to escape through PD-L2, very similar to what has been shown in many, many solid tumors now. And so a broader inhibition through PD-1 inhibition with nivolumab, pembrolizumab may block both PD-L1, PD-L2. So this may become an important differentiation, as is being seen now in solid tumors. In the last part, for immune therapy, there is a very important emerging immune checkpoint pathway, not for T cells now, but for macrophages, called CD47, SIRP alpha. And there was data at this year's EHA, as well as last ASH meeting, with a CD47 antibody, magrolimab, in combination with azacitidine. And this study is ongoing in frontline AML TP53 mutated, as well as frontline intermediate high, very high risk IPSS-R MDS. And as many are aware, the response rates as well as the safety with this combination have been very, very encouraging, especially in AML, quite encouraging in the TP53 mutated AML, which is in general a very, very difficult group, with both response rates and duration and survival looking quite favorable, even favorable compared to azacitidine venetoclax. So that looks like it may be a very specific and important immune checkpoint for AML and MDS. We don't know if it has the same degree of activity in solid tumor. And another immune checkpoint is TIM3, which also seems to have some specificity and importance both on AML stem cells and in AML mature blast. And there are trials looking at that. So I think over 5-6 years, we're moving on from using the general solid tumor PD-1, PD-L1, CTLA-4 that we borrowed from them, to finding and targeting more AML, MDS specific checkpoints such as the CD47, TIM3, maybe down the line, LAG3 and others. And it does look like there will be hopefully a promising future with different combinations for these immune checkpoints in AML and MDS. Thank you very much.